is our moderator, so I can see you all.
Thank you very much, everybody. Let's start online because we got lots of people waiting to hear from us. So this is our third session. It's about evolving novel patient partnership in genomic and personalized medicine and digital health. It's also to look at artificial intelligence and machine learning. There's a lot of things being said as to what genomic medicine and personalized medicine can mean for humanity. With the Jennifer Doudna at one time saying that this is the end of all disease in plant, human, and animal life, that this is opportunity for us to look at CRISPR-Cas9 as a solution for everything. Then you've got other sides saying we've got to watch out the ethical considerations of this. Again, in digital health, I think lots been said. It will provide us with all solutions that we are there. And with artificial intelligence and machine learning, it almost promises us many more things to come. The moderator for this session will be Sanja Njegic, who's the Executive Director and Head of International Patient Affairs at BioMarin. And she's got a very excellent panel here. We have got Dr. Rosyln Schneider, who is Vice President and Head of the Patient Affairs at BioMarin. Then we have got Dr. Sawsan AlMadhi, who is the Advocacy and Advisor and CEO and founder of AlignnEficient Health Consultancy. But Dr. Sawsan also headed tens of patients in UAE, part of also the IAPO. So wears very many hats, as I say, and with many, I would say, wears many hijabs. So she's part of many of this cooperation and working internationally, and has a strong insight in the region and how it's developing, and has also developed the IAPO's Personalized Cancer Care Alliance's position paper on how to deliver predictive, preventative, personalized, participatory, and preemptive healthcare for the WHO AMRO region. Dr. Sawsan also helping us shape our side event on Tuesday, 23rd, where we are honoring the Minister for Health from Egypt, and also Dr. AlMadhi, the Regional Director of Egypt for WHO AMRO, plus other dignitaries. Then we have got Dr. Maira Caleffi joining us from Brazil. Dr. Maira unfortunately could not be with us. We would have really loved to have her here. Dr. Maira is what I say, the conscience of all late diagnosis. As a breast cancer surgeon, she sees that all, the kind of things she has to do and remove, and she keeps positive. I think these are things that could have easily been avoided, as she says. There should be no late presentation of breast cancer in today's age. We should diagnose this as early as possible using the biomarker and other technologies. Speaker 4 is our own board member, Paul Mendonza. Paul is the president of the Psoriasis Philippines. Paul again wears many hats. He's quite a influential patient advocate in Asia Pacific region, and you'll find his name appearing in many things all the time, and has been a great contributor of patient-centric healthcare in the region. With that introductions over, I'll now hand over to Sanja to take over from here. Thank you.
Thank you very much, Cavaldi, and good afternoon, everyone. I hope we will keep you awake because Especially online. Now, thank you very much first of all, for inviting us. Thank you very much, Cavalli and IAPO. It's really a great pleasure to be here, and especially, my pleasure to moderate the panel with such esteemed panelists. So this is really great. So, before maybe we start, we talked this morning about importance of patient partnership and how it's important really to have the patient perspective from the very early stages and across the whole development pathway. But we also heard that it's very important to multi-stakeholder partnerships, and we heard also about the disruption of the healthcare system during the COVID times. But when we are thinking a little bit going forward, medicine, of course, is evolving now. So we are going to go into this area of more complex, if you wish, medicine, which is certainly this area of genomic personalized medicine, where the data will be very important together with the digital. So this personalized healthcare with digitalization and data, how can this actually help to improve healthcare outcomes? I think this is something that we will be addressing today with you. So I would like to turn to Rose Schneider, who is the Global Head of Patient Partnership in BioMarin, to start to talk about that.
Well, thank you, Sanja, and thank you to IAPO for bringing us here to have these very, very important conversations. I'll first disclose that I do work for BioMarin. And at the same time, the remarks that I'm making here today are based on my collective experiences as a patient myself, as a care partner, as a physician, as an advocate, and yes, as an employee of a biopharmaceutical company. But the remarks that I'm making are not necessarily expressing the views of BioMarin or any other organization. So I'd like to talk about, with these complex therapies and modalities like AI and machine learning and large language models, how we can help ensure through patient inclusion, patient engagement, how we can ensure that those are not only increasingly precise and targeted, but are also increasingly personal. Because I don't think it's the same thing. And I think our experience tells us that it's not the same thing. So in doing that, I want to also bring up this notion of two very different but related types of patient and family inclusiveness. And that is using some terminology that has been coined by an advocate who many of you may know, Suze Schrant, who's also a collaborator and a friend. And she has coined this term of Type A and Type B patient engagement or patient inclusion, where Type A is that active involvement of people living with conditions and their families in their own care or in their own participation in research for their individual health outcomes to be improved. And that includes and is really being advanced with digital technologies, the ways that we connect with our personal healthcare teams, the ways that we connect to our own health data. You know, if I look around the room, I would bet that most of us is wearing a health device that we used to call a wristwatch, right? So we're more connected to our health data. How are we using that to connect with our healthcare teams? That's all part of this Type A engagement. And then having this access that is very different today than when I graduated from medical school, we'll say a lot of years ago. And the connection to health and science information that used to be held very closely within the scientific community is now far more available to the health interested public to be able to access. So that, as well as the ways that technology is connecting us to each other as patients, as communities, where even with rare conditions, where your physician may have only seen one person living with that illness over their decades of practice, now in an instant, you can be connected with people all over the world who are having similar or related experiences. So all of these things, I think, fall under that umbrella of type A engagement, which is related to and influenced by type B engagement or inclusivity. And that is patients and families who are engaging in health systems and in organizations and helping to influence policy, which again, in turn, would affect health outcomes in part by influencing that type A patient engagement. So what that is, and this is a lot of the work that Sanja and I do from day in this company and in previous companies, it's really looking at that end-to-end involvement of patients, family members, care partners, and community members, end-to-end from the technology development or medicine development, from that early discovery day, right? The discovery and exploratory phase, when we're thinking about what the unmet need truly is in the community, we should make no assumptions. We have to understand how well served is that community with what we already have, and what is it that they actually need that could potentially be transformational in their lives. We can only know that if we have that iterative involvement with various members of communities all along the way, and at key points in an intentional manner. So at the exploratory phase, at the next phase, which is really the development phase, when we're putting together clinical trials, working with patient communities to understand the hierarchy of importance of certain clinical outcomes based on the lived experience that people have, as well as if they have any specific technical experience that they may be bringing to the table. Because again, we heard this morning that a lot of patients have developed technical expertise in medicine development through the programs that exist. So bringing them in at that point in development as well, and sitting around the same table to say, we're designing a trial, let's also talk about the feasibility of not your participation, but the community's participation in this clinical trial. This is the number of visits we're thinking about. This is how far away it might be from someone's home. How are they going to get there and be able to still live their lives? Because people have a lot in their lives as patients who are also people first, who may have jobs, maybe going to school. The care partners are also doing all of those things, living their lives. What do we need to have in place in the design of our clinical trials to make those trials have as little a burden and an intrusion on somebody's life, so that they will actually stick with it, and then we'll have the integrity of the data at the end to be able to get us to where we want to have that information set that's again going to go back to informing that type A type of patient involvement, so that people can make the appropriate decisions for their own care. So that's, part of the life cycle, and as well as making sure that as these innovations get to health authority approvals and to health technology assessment decision-making, that patients are at those tables as well. And I'm using the term patients loosely, given the conversations that we had today. Unfortunately, we haven't found a better word to reflect the experience of people living with various conditions. But I think it is important not only to get us to approval of new technologies, but also then for as long as a medicine or a technology is available for use anywhere in the world, we need to continue that relationship with the patient community. It may not be the same people at each of these stages who we're connecting with, because we have to match what the interests are, the shared purpose of a patient community or a set of individuals who wants to work with us as sponsors on not necessarily agreeing on everything, but having those points of intersection where we can and should be working together. Because patients are and will remain, even with the fancy technology that we have, patients will remain the best experts, I would say, in their lived experience. So it's, again, iterative, and we need to look and not try and recreate the wheel every time about how we engage with the patient community. We need to look at the co-created, co-developed guidances that came from UICC that we heard about this morning, or Patient-Focused Medicine Development Coalition. There are so many tools that are available for all of us to use, and I think it's important for us to actually use them. So really, just in wrapping up, I'm going to say that in order for technologies, no matter what they are, to be both precise and personal, and to help ensure that safe, effective, and appropriate use of whatever the technology is, we have to, in a meaningful way, integrate the potential for the science and the potential for the innovation with what patients articulate that they want and need for themselves, and how that might fit into their lives. So that's it for me.
Thank you. Thank you very much, Rose. This was really interesting. And I have to say, this is really important how you also define type A and type B, this type of patient engagement, that at the end of the day, you connected it very nicely to the data and the informed decision-making, and how this will actually then inform not only decision-making, but also shape future healthcare systems. So thank you very much for that. And I think this is a great segue to Dr. Sawsan.
Thank you.
Thank you. Sorry.
I do have a presentation. Somebody can help me pull it up. Yes. Good afternoon, everybody. Just want to comment on one thing, because it's interesting how we are all caught up with the vocabulary when we're talking about patients. And I don't mind actually the word patient, because and if you come from any faith, patient is actually a virtue, isn't it? So if we look at it from that point of view, and people who used to come to my speeches, I always remind them that patient is not an adjective or a stigma, it's actually a virtue. I think it's the action behind the patient. I think this is what we're trying to do here. So I don't want us to get caught of what we should call what we're doing. I think we should move forward with that. I hope that helps. So going back to my session, can I have the next slide, please? So we're talking about how can patient partnership in personalized and genomic medicine and digital health and AI machine learning. Very important topic. Most of us working in the sphere of patient advocacy, we understand that this is the future. Unfortunately, it's not the future, it is now, especially when we're talking about AI. So what I'm trying to do right now is explain to you that IAPO 2 years ago, they actually took upon themselves to create something called the Personalized Cancer Care Alliance for the EMR region, for the Eastern Mediterranean region, which I represent. And part of the work that they have been doing for that past 2 years is co-creating with patient organization from the region, and they have developed a position paper. And this position paper is a big advocacy tool for patient organization to start speaking about personalized cancer care, but not just speaking about it from an advocacy or awareness level, but also from how can we implement it, how can we work with policymakers to make this happen? Because we all know that. We all have worked with policymakers where they think that this is too expensive, we have to think about, a bigger picture. They always have I don't want to call it an excuse, but they always have an answer when you try to lobby for more funding for, genomic medicine or more cancer research. So really, the personalized cancer care position paper is an excellent tool for anybody. I would love for everybody to actually access it. It's on IAPO portal, to access it and see how can they work, although it was tailored to my region, but still I think what IAPO wants to do in the future is see how to expand it on other regions as well. Can I have the next slide, please? Next slide. It would be easy if we have a clicker here. No? So we're talking about digital medicine and AI, and we don't have a clicker. Oh, okay. Digital. Okay. Still lots of gaps, isn't it? Okay, so this is what I'm going to do today. I'm going to be very brief. Next slide, please. My manual clicker. Next slide. So I already mentioned, yes, thank you very much. So Personalized Cancer Care Alliance, as you can see, very meaningful logo where you have a person in the middle of everything. And the Personalized Cancer Care Alliance was set up because we know how and what, not all, what we know what patients need and what they don't need. And so although cancers are not the same, patients also are not the same. So it wouldn't be fair to treat who has breast cancer as an example with the same protocol, which 20 years ago was acceptable. But now we are in 2023, that is not acceptable anymore. Next slide, please. So again, this is the position paper. You can access them through the IAPO website. Next slide, please. So the personalized cancer care, and I believe lots of our esteemed speakers today mentioned that earlier. It's all about giving the right treatment, the right patient at the right time. There is always better outcome when we do that, and also there is always better patient safety and reducing of the adverse risk event, which, you know, as healthcare providers and of course as patient and even carer, this is what we want at the end of the day. Now, there are lots of health technologies like personalized cancer care that's in our disposals these days. Lots of the technology you mentioned as well, Rosyln. But the problem is that the current health systems, and I keep on hearing the word system from the start of the day, everybody's saying the system, the system. The issue with the system is it's not yet equipped for the system to be ready to receive personalized care, whatever it is, it's for cancer or for other non-communicable disease. We decided in the position paper that it should have 5 pillars. It should be predictive. The system has to be predictive. It has to work on the element of preventative. It has to be participatory. This is where the patient comes in. Personalized and also preemptive. And we call those the 5 Ps. Next slide, please. Now, the 5 Ps is all about leading to more well-functioning and healthcare system if rightly implemented. Of course, this is what we call the Shangri-La of health systems, I think. But this is what we're hoping for, which I believe is doable. Next slide, please. So what is predictive? I'm going to go through it very, very fastly. So predictive is to be able to predict who are my community that I need to screen. Who are my community that, and of course for that we need to have really clear cancer data, and we know that lots of the countries, especially when we talk about my region, my region is kind of very diverse region where you have very high income countries like the Gulf states. I come from United Arab Emirates, from Dubai, and you have also low and middle income countries as well, and countries that really doesn't have a system per se because of all the political and economical turmoil that's happening. So cancer data, cancer screening, cancer control, cancer analysis, all these are important when you want to work in the preventative domain of the first P. Next slide, please. Next slide. Next slide, my manual clicker, please. Yep, thank you. So participatory, I think this goes without saying, it is a co-creation, a co-development between the patient. It's very important, of course, the health system. And this is very important because it's going to make the health system more efficient, more effective, and also will deliver value for money. I think Nicola was there in the previous session where she was speaking about how important it is and the value-based outcome. And this is actually where lots of the health system is actually moving towards, because we cannot solve the fact that health technology are expensive. We cannot solve the fact that healthcare is becoming expensive. What we can do is drive everything to value-based. I was told I have 2 minutes, so I'll just jump very quickly. Next slide, please. Personalized, I think this goes without saying. Personalized is using the health technology, using genomics to determine what type of treatment I need to give a patient. And I did mention before, you can have 10 breast cancer cases, you cannot give them the same protocol. We do have now enormous information when it comes to the diverse of genetics that we can use and build to really prescribe all the innovative new medication that's out there. Next slide, please. Preemptive is building back better, and I think we've seen this, I think, as almost like a mantra during the day. Is like, we want to build better, we want to build better. Of course we want to build, but the only way we can build better is to preempt, is to understand what is there in the future. We cannot predict, maybe in the future we can, but right now what we can do is see what's happening and look and moving forward with key learning on building and being preemptive. Next, please. So the P's, we already did the 5 will give us really good, amazing patient outcome. It will enhance the patient experience. It will match the patient preference, but also it will make the health systems much better. And that's what we're hoping for. Can we move forward, please? I'm not going to go through this. Can you go more? This is examples how can a health system be all of these 5 Ps. I'm going to skip them. Can we move more forward, please? More. Working. Yes. So since we are talking about AI, I actually asked ChatGPT. And I said, ChatGPT, what do you think about personalized cancer care? That's the answer ChatGPT gave me. AI agrees. Let's put it there. And then I love to play with ChatGPT. I actually asked them, if I get insomniac at night, I just open ChatGPT and ask all those silly questions to ChatGPT, and I got all the silly, they learn from us, yeah? So next slide, please. So I asked them the other question. Can we go to the next slide? What is the role of patient organization in all of this? So ChatGPT agreed with me. Yes, it's amazing. This is the way forward. So ChatGPT said, patient organization can play. This is not me, yeah? I'm a patient advocate, yeah? And that's what I do for a living. But that's what ChatGPT said, that it can play a crucial and integrating of genomic medicine and personalized cancer care for national cancer control plans. And the way you do it is by advocacy, education, research, and collaboration and support. In summary, patient organization can serve an important advocate, education, collaborator, resource of support patient and their family in the context of genomic medicine. And you can definitely go and ask ChatGPT as well. I'm sure they're going to give you, I already feed the information, so they're going to give you the same thing. And can I have the next slide, please? That's it. Thank you very much.
Thank you so much, Sawsan. This was really, I would say, enlightening. First of all, how you publish data and how you talk through the data, and developed an advocacy tool, and translated also in several languages, which is really fantastic. And then also, how you made such a complex topic. I don't want to say simple, but at least something that is close then to the countries, to the people who have to advocate through those.
That's advocacy work, isn't it?
Yes, it is. And then ChatGPT, I think, it was just fantastic. And I think it's a great segue then to I believe, pre-presentation that we will hear from Dr. Maira Caleffi. And this will be very connected and important what you, Ros, said, and Sawsan, because this will walk us through the implementation of the National Network on Breast Cancer in Brazil. So if we can have the presentation, would be great. Thank you.
Hello everybody. I'm so sorry I cannot be at the 10th Global Patient Congress from the International Alliance of Patients Organization. I'm really keen on being there, but unfortunately it was not possible. So I'm here to share with you some thoughts of the patient's view and the medical professional's view on the subject. And I'm going to share with you some insights on the implementation of a national network of breast cancer in Brazil, how the patient advocacy work really interfere and is interfering for personalized medicine cancer care. I am Dr. Maira Caleffi from Brazil, and I see patients every day, and for the last 30 years, I have been on the leadership of patients groups advocacy. So I'm going to share with you some ideas of humanized healthcare and cancer, as I am part of the external advisory committee of IAPO. I'm so proud of it. I'm going to share things about the challenge to overcome cancer access barriers in Brazil. Talk about a little bit about FEMAMA, and I'm going to show you some case studies and how the social control through civil society can play a very important role on health systems. Well, IAPO says patients are the most important stakeholder. Patients must have a seat at the table where decisions are made and solutions are co-created. This is, for me, is a dogma, and I have been pursuing this statement in Brazil for the last more than 20 years. And FEMAMA really, with some people that are having the same aim in life. I'm here to tell you something about FEMAMA, the National Federation of Philanthropic Institutions to support healthcare towards breast cancer. We were born from the inconformism, the indignation with a scenario that is really, really very hard, because there are many, many lives being spared of cancer, breast cancer, that could have been diagnosed earlier. So we are really, really to increase the access to breast cancer diagnosis and treatment for the population and decrease breast cancer mortality. We were founded in 2006 from an experience that started in 1993 in the state of Rio Grande do Sul with Instituto da Mama, Rio Grande do Sul. The challenge to overcome cancer access barriers in Brazil at the moment is really how we can put really people at the heart of healthcare, how we're going to increase literacy, how we're going to build capacity for harnessing the power of the patient data, how we're going to prioritize diversity, prevention. Well, we have so many issues that are very common to IAPO, and we are here in Brazil to support all that movement. So FEMAMA's network is throughout Brazil, and we almost can paint all Brazil with pink, and we are 75 NGOs, well, officially formatted in almost all regions of Brazil. 20 states out of the 23 states, plus the federal district, that is Brasilia. Together with this national network, we work with Todos Juntos contra o Câncer, that is like all against cancer, that we have this movement. We have a seat at the National Council for Health, and we also work together with the Latin America Alianza Latina. Well, after I just said that we were born in 2006, we really conquered many achievements, and we managed to push. We are an advocacy group for health, better access, improving access, and improving adequate treatment. So we already put through the mammography law, over 40 years old, the 60-day law that perhaps you heard of it, that is the inspiration for the Global Breast Cancer Initiative at WHO. We play a very important role in innovation to pass and to make access to innovative drugs as oral drugs, trastuzumab, pertuzumab. But really, 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 what I'm here to tell you what is going on in Brazil is that we are playing a very important role in genetic testing access. I'm going to tell you about two cases. Case one is a federal bill that FEMAMA is trying to pass with the support of Congresswomen in Parliament, a bill that will give access to germline genetic and genomic tumor testing, according to medical needs, of course, but to all Brazilians for prevention, diagnosis, and adequate treatment for breast and ovarian cancer. This is really personalized medicine. That is the topic of today. So I'm going to leave the slides for you to have access. And this is how FEMAMA works. We have to consider it and to educate not only the public population, but also the politicians, why this is so important. And we're still on the process because advocates know that we have changes in government. We just changed the government last year. We have to play according to the political best moment to pass bills. Next, we have already 5 laws, state laws for genetic and genomic testing. I'll tell you, 70% of the population, perhaps in some states, 90% of the population, only depends on the universal health care coverage. But we don't have testing, genetic testing on those states. So, in most of states, sorry. So we have genetic and genomic testing in 5 states, and FEMAMA is trying to organize how we can implement from after the law being approved, how patients can have access to the law and testing. Next. I'm just going to tell you that social control to civil society and health system is a conquer of civil society in Brazil. We have now many ways that the civil society can play an important role to pass bills and to influence. It's very interesting that the word influencers now is very fashion, but we are being influencing politicians and government to have more access to breast cancer diagnosis and treatment. This year is a very important year to Brazil because it's going to happen the national health coverage where the public can organize from local municipalities, state and national, their asks what they think has to change in healthcare for the future. This is a very important time for us advocates in Brazil. Next. And FEMAMA is organizing open conference, mobilizing patient associations, political leaders, and health professionals from all over Brazil to elaborate proposals that will be integrated to the national conference. From the national conference will be a document that is going to be sent to the Minister of Health, and they're going to hear from the civil society what is needed. Next. I think this was an overview of what's going on in Brazil, and I'm really, really proud of what we're doing here, but I'm also very open for you to access presidencia@femama and to tell you that if there is something that can change and transform the world is when patients together can play an advocate role. Thank you very much indeed, and thank you for the invitation.
Excellent, always passionate speeches by Maira. It's amazing what she also tried to achieve and achieved, right, in personalized healthcare and also implementation that she was leading in Brazil. So this leads me to Paul, who will be talking to us about psoriasis and digital health in Philippines.
Hi everyone, so I am Paul. So I'm representing Psoriasis Philippines and Psoriasis Asia Pacific, which is the regional arm for International Federation of Psoriasis Association. And I'm going to talk about telemedicine and how it affected care for psoriatic diseases. Next slide. So before I start, I just want to read this definition from WHO about telemedicine. So telemedicine is the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of diseases and injuries, research and evaluation, and for the continuing education of healthcare providers, all in the interest of advancing the health of individuals and their communities. Next slide. So I know that this is very common to everyone, especially when COVID happened. So this time, so why was this a big factor for us? Because through this television, we have real-time consultations with healthcare professionals, and it's in our own convenience, it's in our own time, without having the fear of going out. So next slide. But of course, when this trend started to happen, a lot of questions arise to the patients. First is that, is it reliable? That's the number one question that pops us to our mind, since we are very used to seeing doctors face to face. And one survey from Brazil, before they experience telemedicine, their perception of it is not 100% sure, or their confidence on it is not there. But after they've tried doing the telemedicine and continuously doing it, they had a positive response on their outlook for telemedicine. And another problem, especially for us, especially in Asia Pacific, which is a group of islands or a lot of places that has no professionals or experts in the condition. So the question is, how do we access it? Where do we go? And next is, besides asking where do we go, how do we do it? Since this is something new, this is something that they are not familiar with. Next slide. These are the challenges that we've experienced. So, of course, where to access. When it comes to digital health literacy, it's very important because especially for those who lives in the rural areas, not everyone is tech savvy. And even though that mobile phones, there's an app available, some of the apps that doctors are using are not familiar with them. And of course, technical issues when it comes to internet connection, when it comes to how do they send the right data or questions to the doctors. That's something that they are also have problems with. So next slide. Okay, so what we did as patient organization, we started talking with different societies, especially for dermatology and rheumatology in our case. And we've partnered with them and asked them that in case that some patients want to have a consult, will you be willing to have these consultations with the patients? So we've talked first with the society and then with their training institutions, both private and public hospitals. We've also partnered with them so that we can disseminate how the patients can access these consultative meetings. Then creating awareness, since we are the ones who talk with the societies and medical societies and other hospitals, we've started posting it in our social media platforms that these are the list of the hospitals. These are the procedures of how you can access these consultations online. And of course, besides that dissemination, we also have patient navigation, wherein that we have this SOR coach program where we train patients to lead other patients in their psoriatic condition. And they are the ones who answers the inquiries from members and patients who wanted to access this teleconsult. Next slide. So what are the benefits of telemedicine? First, it increases access to care. And we've, based on the feedbacks that we had from our members, maybe just a brief background that when it comes to psoriasis, we all know that there is no cure. And most of the patients, once they heard it, they don't want to go back to the doctor because it's just the same story. There's no cure for that. You're just gonna manage it. But when telemedicine became available, their behavior somehow changed and goes to the doctor. So it improves their repeated consultations with the specialist. Of course, it's convenience for us because most of us are afraid to go out because of the stigma, the discrimination, and besides that, because of some of the physical barriers, some are hard in walking or moving around. So it's very convenient in our part. And third is that it improved monitoring. Since it's so easy for us to just take a photo of our lesions or message our doctors to say that this is what we are feeling, this is how it looks like now, this is how the pain level decrease or increase. So the communication was easier between patient and doctors because before when we're doing the face-to-face consultations, there's always that barrier from doctor to patient. And sometimes patients doesn't really ask or if they have some question in their mind, they won't ask the doctor. They will just listen what the doctor will tell them. But through telemedicine, it was easier for them to communicate with the doctors. And another good thing is that it improved adherence to treatment. So before, for psoriasis patients, most of them self-medicate. Because since it's a lifetime condition, the prescription that they had years ago, that's the same prescription that they will use again and again. But because of this improved consultations and communication with their doctors, adherence to treatment has improved greatly. And next slide. Of course, although it's very new and convenient, we have the gaps in using telemedicine. First is that it's limited to physical examination, especially if you're having psoriatic arthritis. The rheumatologists or the doctors won't be able to check your joints or your movement and everything, and lack of personal interaction, which is very, very important. So again, moving forward, we hope that with this telemedicine that, next slide. So it's very interesting, the things that we are talking about, artificial intelligence, machine learning, and we are very, very excited about it. But I would agree with the speakers ahead of me that although these technologies could be available out there, but we need to understand and include patients' input because we are the ones who are going to use that. And also look at the landscape, if it's feasible and doable, or if the, as you say, the healthcare system, is it ready to integrate these new technologies? And hopefully, we have the holistic care, that holistic and personalized care, that we will not just focus on the physical, but also the emotional, social, intellectual aspect of the patient. Then, of course, most important, it's that it's person-centered and integrated approach, especially that psoriatic disease is not just a skin condition, but a serious non-communicable disease that has many risk factors of conditions as well. So we need an integrated approach where one doctor can easily communicate and manage one patient with different issues in their health. So thank you very much.
Thank you very much. Thank you very much, Paul. This was really really great how you started from the telemedicine, also how you see the future now, especially the importance of patient engagement in developing those tools, right? And then making sure that this is actually feasible, that can be implemented and benefit then the health outcomes in the respective systems. So we talked a lot about personalized healthcare, and before we ask the audience, maybe allow me to ask you a few questions. So I think the natural one is, do you think, and this is the question for each of you, do you think that one size fits all healthcare, this era is over, or we are still there? How do you see it? Sawsan, would you like to say?
Yes.
I see that you have the answer already.
Yeah, I think it's an interesting question because that's the debate, isn't it? And in my presentation, I did mention the readiness, and Paul mentioned the readiness of healthcare. So I think the best way forward to respect that there are some countries will not be able to make that transition because of the socioeconomic or whatever political or whatever condition they are going through. Saying that, I believe that if you were talking now about humanizing healthcare, that's the best way forward, is that we need to start personalizing healthcare to make it more human. The funny thing is, if you sit with any industry leader or any healthcare provider, they always mention, and I always challenge people when they tell me this. They always say, "Oh, we're very patient-centric," and I go like, "Fantastic. Let's go for a coffee and tell me what's your definition of patient-centric." And 99.9% of that coffee meeting will end up that they do not really understand what patient centricity is all about. And we're moving from, and now the trend as well, if you're working in the sphere of patient centricity, which is a very, academic discipline as well, we are now moving from patient centricity person, and this is where patient-centric care, and this is where we're saying personalized. We're not saying patientalized, we're saying personalized. So it's the person. Again, the stigma behind the word. So I do not think that going back to your question, and I'll finish in 1 minute, I don't think that one size fits all is relevant anymore in this current era. I think it was a good solution for us before, and aeons before, if I may say, but it might work for some countries for reasons regarding their condition, but for sustainability, I don't think this is the way forward. I hope I answered your question.
Thank you. Absolutely, you did. Rose, what about you?
Well, I completely agree that medicine and healthcare is always personal to the people who are living with the condition. It always has been. So this idea of true one-size-fits-all, in my mind, never had a place in healthcare. So I would like to believe that the notion of really one-size-fits-all without consideration of the person in front of you in that patient healthcare team interaction, that's gone. I practiced medicine for 20 years before joining the industry, and when people talk to me about the patient, I don't know who that is. There was never the patient. There was only the person and their family sitting in front of me having that conversation about what their healthcare goals are. So I don't believe we can have a one-size-fits-all solution.
Thank you very much. And how about you, Paul?
Yeah, so I agree that there's not one fit or one style that fits everyone. I think it's very important that every care that we give is personalized to the patients. Like for psoriatic conditions and other autoimmune conditions, my trigger is different from someone's trigger. And what works for me might not necessarily work for you. So I think that understanding that person better and fitting the right approach to that person to get better for their treatment and manage health management, I think it's important that it's very personalized.
Thank you. You've been all touching also on the challenges, on some of the challenges, right? And we heard also from previous panels that the industry and clinical teams developed also new abilities in developing these innovative medicines using genomics. So do you think that patients are ready to participate and share their medical records and other information to inform better care, or this data sharing topic always somehow comes into the place? Would you like to start, maybe, Paul?
Okay. From a patient's perspective, I think it's very helpful. But first is that we really need to explain so that patients could understand, especially for conditions that has no cure or has high morbidity rates. I think it's a dream that with all of this data, with all of these live experiences, it would help other patients to be better and for them to control their needs. But again, with the issue of data privacy, with the issues on ethics and other stuff, I think that besides explaining it to the patients, it's not just asking them, give me your data, give me your experience, but I think it's better that if we could present, I mean, of all the things that we've talked about, it's always been collaboration, it's always been about partnership. So maybe before you even ask patients, what's your experience, what's your medical records, maybe before you do that, you include us in the discussion that this is what our plans, this is what we want to do, what are your thoughts, would you be amenable to this, and just give them also the big picture that this is something that we need to work together for improving healthcare for everyone.
Thank you, Paul. This is so important. Maybe this is the segue to Rose. What do you think?
Sure. I think in general, people are willing to share their data if they're sharing it with an entity that they can trust. And I think trust is earned and mistrust is earned. So we have to be very careful that we build in reasons to trust whoever is asking for that sharing. And so that we very clearly articulate why that's important and of what benefit it will be for the whole community, because most often it's not going to be of individual benefit for the person who's sharing at the moment. So I think the transparency of why the data is needed, maybe it's are needed, but why they're needed and then how it's going to be used helps to build that trust one drop at a time.
So absolutely. I mean, I couldn't agree more with both of my esteemed colleague, and I think it's interesting because it goes back. There is also a common thread that we have been talking about health literacy from the beginning of the day. And I think lots of people think about health literacy is about me educating the patient about their disease and educating them about the treatment they're taking, what's the side effect. But literally, many patients don't understand that the file that they have in the hospital is not the hospital. A hospital is actually a custodian of that information, and that file belongs to the patient. 99% of patients don't understand that, and this is data as well. Again, I think another thing which is very interesting is when you say to the patient, I want you to give me your data. Sometimes the word itself, again, we're going back to semantics here. What the word itself can be, what do you mean by that? And I agree with Paul, is that it is clearly explained. And also, if it clearly is in partnership with the patient, that we're going to use that information for the better good. I mean, any one of us in this room, would we not to share any of the information we have if we know it's going to benefit the greater good, if we want to call it. So again, it's proper communication. It's understanding as well the limits of what we want to educate patients about when we speak about health literacy, because I still think there is a lot to be done in that area. And again, as Rosyln said, which is very important, is the element of trust. Absolutely. Over to you.
Thank you very much. Yeah, no, I was also going to comment on the trust is the first thing,
Absolutely.
no? Right. Also, when we talked about the multi-stakeholder engagement, and then the patient perspective into this, this is absolutely the first thing. And as you said, if there is no enough health literacy, if there is no enough understanding, where this data will go, what this really means, and why do I need to share them, then there is no trust there. So this is all connected. That's great. So maybe another question could be, we touched a little bit upon, but do you think, if we think about the balance today and going forward of the future of the healthcare, do you think that personalization of healthcare promises more choice and better outcomes, or is there a risk somewhere? Rose, would you like to start?
Sure. Well, definitely promises better healthcare and more choice. The question is, will it deliver on its promise? And that, I think, is the great risk. Will it actually enhance access and connection for people who are less affiliated, who are in systems that are not as well connected, or will it actually amplify some of the biases that we have in the systems? We know that algorithms can have biases,
Absolutely.
right? So if we start then designing systems that again amplify those biases, then I think it can't deliver on it. But I do think, I don't want to be too nihilistic. I think the promise is there, and if we work with appropriately representative patient communities, that we can make sure that those systems serve the people who they're intended to serve.
Thank you very much, Rose. What about you, Sawsan?
I mean, my whole presentation was about personalization.
Yes.
Seriously, I have nothing to say but yes, yes, yes. But I do agree with Rose, and I'm a little bit worried about the word promise, because promise is a little bit, carries so much connotation behind it as well, because then you're building a hype and expectation at the end of the day, which can be delivered. There's no, there's no never say never, as they say. But I think the idea, and I do agree, there can be biases even with AI, but this is the beauty of AI. It's actually learning, ChatGPT is learning, and other AI platforms. But I think this is where people like us sitting in an amazing Congress like this, I think this is where we can actually make sure that the future is shaped the way we wanted it to be shaped. That's the quick key here, because the future can be shaped by others as well, but the best future is the one that you make yourself, for yourself. And I think that might be the takeaway home for me, at least, from this session. Over to you.
Mm-hmm. Thank you.
Yeah, I think it's really good. In a perfect setting, in a perfect world, it sounds great, and for us, it's very exciting. But yeah, I do agree with some biases in terms like when you feed the data, I think that everyone should be there. Everyone should be included. Because some of the things that we always say when it comes to Asia Pacific is that, for example, most of the studies are in the Western, but there's no studies in Asia Pacific. So how would you, if we'll just rely on data inputted in AI, is the data of the population that you want to target is also there? Are they represented? Mm-hmm. So I think it's very important that we catch everyone.
Mm-hmm. Thank you. Yeah, this inclusion is definitely important. And as you said also, the high expectations, then the devil is always in the details, right?
Absolutely.
So to actually meet those expectations and really implement for the greater good. Okay, now Rosa, I have one question for you. So we hear that the family that eats together stays together. So in your experience, would you say a family and community that participates together in technological advances will stay healthy together? And this we ask because many of these genetic diseases and disorders impact not only the patient, but also the family and the relatives and the community.
Well, there's a lot in that question. And I would say it's relevant not only for genetic and rare conditions that it affects the whole family, but that any diagnosis really affects more than the person who has that diagnosis in the complex social structure that is a family, right? And I think we have to start by saying we need the perspective of those family members and care partners when we're thinking about anything that pertains to healthcare, because those lenses are important, and because, for example, for care partners, we know that the impact on their individual, physical, emotional, financial, and social health, the impact of the other person in their family having that diagnosis can be very significant. So we need to understand that if we want to understand the holistic patient experience, we need to understand the holistic family experience. So make no assumptions. I would also not make the assumption that the family that eats together stays together. I would also say that in that complex social structure, when you're eating together, you don't necessarily speak harmoniously to each other and agree on everything about what everybody at the table wants. So we want all of the input, but we also have to understand that may not be aligned on what's needed for that individual.
Yeah, so true, so true. Thank you so much, Rose. And Sawsan, so you very comprehensively looked at the personalized healthcare in your publication, really from all stakeholders, and you have recommended unequal weight patient participation with making healthcare with 5 Ps, right? Predictive, preventative, personalized, and preemptive, right?
Yes.
So what value does participation bring to the whole continuum you recommend?
I mean, if you really include, and again, I voice Paul, he keeps on knocking on that same nail with the same hammer. If you really include all the stakeholders that you want to include, absolutely, the result would be amazing. It's like at the end of the day, and I don't want to, diminish any of the thing that I said, but it's like when you're making something at home and you're something, and there's no, of course, comparison, but if you're missing one element, that the recipe will totally change, isn't it? And again, maybe it's not relevant, it's not relatable, but that's how my mind is looking at it. So if you look at position paper, and I did put the link in the presentation, and if you look at it, you have also key opinion leaders speaking about the importance of personalized cancer care. And if we sit together now and we said who would be included, so everybody will agree, an oncologist would be included, a researcher would be included, somebody representing patient organization, which was Caleffi, actually he was also included, another patient organization and oncologist was included. But interestingly enough, there was somebody who was included who spoke about blockchain and how can blockchain work with health system to improve the accessibility of patient file, but also to improve on the 5 Ps.
Amazing.
Can I drop the mic now? So basically, that's the kind of participation we're looking for. It's, again, you have to ask the right question to get the right answer. We all know that. That's a basic in communication. So when I'm thinking about who I want to participate in, so I want to participate that guy who thinks that blockchain can actually enhance. We are in healthcare. Look at the financial system. I know that there is lots of negative thing happening there, but in general, they are incorporating technology. They are incorporating blockchain, NFTs, all those technology. Where are be a system when it comes to that. And again, we're saying, oh, the system, the system, the system. Yeah, because the system, we are operating a system in the 21st century, in 2023, with the same system that we were operating. Can I say 50 years ago? Can I be pessimistic and say 50 or optimistic and say 50 years ago? That's the problem. It's not going parallel to what's happening. Things are moving very fast, and we're still thinking about why we should engage patients in our discussion. Again, I'll just drop the. Thank you very much. Over to you.
Thank you so much for this. No, I mean, that's really so true, you know. That's so true, because I think also when you're working in that level, you know, everyone is talking about multi-stakeholder engagement.
Absolutely.
But your question is so right. Am I considering all the right stakeholders, and then AI, and then the digital, and then, you know, all of this, robotics in the future? So did I take into account all of that? Because otherwise we are always talking in the same circles, right? And nothing really
And
moves forward.
I really recommend everybody who is listening to us virtually or in the room to really look at that opinion leader is in the middle of the position paper and look at how he's rationalizing it and how he thinks this will actually improve in the health system and makes personalized care even possible. I have no idea how that would work personally, but I'm sure somebody out there can, you know, from the other industry sectors that can help us with that. Over to you.
Absolutely. Thank you. Thank you very much. And Paul, you were talking about psoriasis. You were also mentioning stigma very much of psoriasis, and how actually through telemedicine and digitalization this was sort of overcome, right? So the question actually is, biological originated drugs played a big role in improving health and well-being of patients with autoimmune diseases. So do you think that more needs to be done in educating patients on biologics and biosimilars?
Yeah, I think educating patients about these new treatments is very important. But before I want to go there, the more pressing issue is the accessibility of these new medications. Especially a lot of countries in Asia Pacific has no access to these biological treatments. I mean, they are available in the market, but because of the high cost, these patients cannot access these medications. And like for psoriasis, there's no health policy for psoriasis in the Philippines. So it's more harder for us to access this medication. So though I think that that's something that we should also focus also, not just educating the patients about these new treatments, but also improving the access to medication, and even for new drugs to be available in the country itself. Because I mean, I have a lot of news that's already in the pipeline or going in our country, but because of the legal stuff and the papers and everything, there's some delays, and there's a lot of issues that we need to focus on as well.
Thank you very much. Are there any questions from the audience? Or online? Right.
Hey, thank you very much. My question spans from the discussion on personalized medicine, precision medicine, basically, yeah. And then I want to ask, how does treatment guidelines and treatment protocols, how can we modify guidelines and protocols to suit personalized medicine? Because for my understanding, a protocol means for every single patient, this is how we're supposed to treat the patient, this is how it's supposed to go. So with our discussion, how can we modify it to better suit personalized medicine? Yeah, thank you.
Now, Sawsan, would you like to take this?
Yeah, of course. First of all, it's interesting how, thank you very much. I'm sorry, I didn't catch your name. Priscilla. So it's interesting how you started with defining personalized with many definitions, and that's actually one of the first things that the position paper is arguing. And it's saying there is no clear Everybody's using a certain terminology. You use precision medicine, you use personalized care. So there's no certain definition that was actually even unified, even within the medical sector or even within the WHO as well. They're still using precision medicine. And this is why we tried in the position paper to continually be consistent with the terminology we are using, because this is a seminal position paper that we're hoping later, as Kawalid mentioned, there will be tools developed from it, but we're hoping that this will be a bigger collaborative even with UN agency to make sure that we're talking about a certain definition for personalized care, whatever that precision medicine or whatever that is. So that's actually a good point. I'm glad actually you used more than one terminology to steer up the discussion. The other thing is, again, I think it goes back to the question from Sanja. You mentioned one size fits all, and you're talking about protocols, yeah? And you're talking about what is been done now or has been done before. What we're talking about creating, let's use the word protocol just because we don't have other better words to use, for every patient. So there will not be, again, if you have, as a doctor, if you'll have 10 cancer, let's say 10 breast cancer patient in the same ward, if you graduated medicine like me 20 plus years ago, you would know that there is a certain protocol that you're going to use for that's the chemotherapy, that's the radiotherapy, whatever. That's not how we're going to do it anymore. We're going to say, this is the patient. We're talking in the position paper about using biomarkers. We're talking about liquid biopsies. We're talking about all these new health technologies that are being now developed to determine that that is the protocol for this patient. And that will not and cannot be used or duplicated for another patient. So again, I'm not sure if that's going to be the name protocol will still be used in the future, which is now, the future is now, or there will be a better terminology. But that's actually, thank you for raising that, because that might be actually another chapter to be added to the position paper 2.0 next year. Thank you.
Other question?
Oh, thank you very much. Tessa Richards from the BMJ. Ros, I rather liked your description of care being personalised to the patient in front of you, but also about precision medicine being the most, sophisticated and effective medicine available. But do you not see a growing tension in this brave new world of ever more effective screening tests, diagnostic tests, treatment protocols, that with finite resources, to be fair to all, there will be difficult decisions and balances to be made? You talked about an individual family where a patient's family may not think the same about what is in the patient's interests. Different family members will have different views. Well, write this to the community as a whole. Who decides what should be in a country's basket of care? And who decides, how do you decide? And that seems to me that that's going to be a bigger and bigger question as we move forward. Obviously in the UK we have NICE, and sometimes you can't get a treatment that you want because NICE won't fund it under the NHS. Do you see, more of this happening?
I do, and I see, again, the involvement of the patient community as critical in getting us to equitable, let's say, distribution of choice, and where a holistic look at various types of therapies may be that because it's more precise, because it's more targeted, even if it's more costly, there are a whole bunch of other people who shouldn't get that therapy because it's not targeted for them. So it's a shift in costs, and I'm not an economics expert by any means, but I think it's a matter of considering all of the aspects of value. And now, thankfully, more and more patients and patient organizations are being involved in building patient value frameworks. Patient-included value frameworks, because some of the earlier frameworks about value didn't include patients. So I think we can't have the discussion without including the community and without addressing those very hard questions, to say there is still always going to be a limited of resources. How, in an already unequal world of health, will we make sure that we don't make it more unequal, but that we try very, very hard by working with all of the stakeholders to make it as equitable as possible?
Another question.
Hi, everyone. Thank you. Great panel. Great discussion. I have, I guess, a comment and then a question. The comment is around, and it's really for industry folks. I should introduce myself. I'm also suffering from jet lag, so. But Carrie McDonough, I work at Syneos Health, and I lead our Patient Voice Consortium. And so I work with big, small, biotech, the whole kit and caboodle when it comes to drug development and commercialization. And one, I guess my call to action is, as we think about data and data ownership, is just encouraging folks to really consider returning data to patients who are participating in clinical trials. I think that that's just in an era where everybody's data is flying around, and I think the latest Scripps data showed that it was like 45% of patients never find out if they were on placebo. There's some barriers there. But my question is around, because I do work with a gazillion different, people across industry, and some are super sophisticated, like the folks showing up here today, probably, and then some that aren't. And then because we live in a world where everybody wants to embrace the vaccine, and some of the core fundamentals about what we're talking about, requires building trust, which is not fast and it's not sexy. It's real. And I guess where I'm going with this is I've been hearing a lot from folks about, hey, we can cut out like a whole piece of the process because we don't need to engage with actual patients in bidirectional iterative ways. We can just look at, ChatGPT and find a patient journey map that way. Or we can just look at all of the, all the access to all the medical records that we all have now, at least on the industry side, and, make assumptions. And so I guess, what would your response to that be? Like the idea of using data that's already out there as a proxy for bidirectional communications that take some time to build trust, especially with those that are typically most silenced. Sorry, that was a lot.
Thank you very much. Rose, would you like to take this one?
Sure, I'll just touch on it because it is a big topic, of course, that patient experience data doesn't mean that you don't need patient engagement in having the background, the color, and the context for the patient experience data. So I think we need both, just as I think we need artificial intelligence and all of this machine stuff that's becoming more and more humanistic. We have to remember it's not. So if we use them to complement each other, I think we'll be in a much better position than if we say, oh, we don't need that because we have this.
Can I just drop one comment? So for your question, I'm going to ask you a question. So you're saying if I take AI and supplement that as a proxy for patient, so that's an argument, very fair. So does that mean that if I'm a patient, I can ask ChatGPT for my diagnosis and treatment? Yeah, I've been seeing things. So we're trying to be logical, at this point. So again, I do agree. Also, if you look at historical data, it will not capture the generational as well information, and that is very important. You have now, we're bypassing now the patient where they were, baby boomers, Generation X, Generation Z. Now you have the millennials, you have the post-millennials. So all those, if you go just to historical, then you are missing on a very important gap in the community. So again, that's also food for thought. And just one more comment for Tricia from PMG, I believe. Tessa, sorry.
Tessa, yeah.
So just one comment is that personalized care is not, it's very new. And we need experts to work on investment cases. We need numbers to show policymaker, because when how much it will cost them to build a genomic center or invest in in liquid biopsies or genomics testing, they literally will have a heart attack. You know, like no, this is too much money. But I agree with Rosyln, when the issue is not now. The issue we're building for the future. Yeah, we are building better for tomorrow. If we get investment case, we get experts who can actually prove crunch numbers and say, if you spend X now, I bet you're gonna really save in the future. And the most important thing also, you are investing in your human capital. It's not just the financial capital. There's a human capital that we need to think about. So we need that. This is brand new era for all of us, and we need those experts to come on board and help us define the investment case that we can go, because politician only cares about number, and I agree with them. But we all run organization at a certain point in our life, and it's all about budgets at the end of the day. We need that as well. So that's still, hopefully in the future, we can have experts that come on board, again, multi-stakeholder participation, and we can have that discussion.
Stakeholders outside the health sector too. You could say the one
Yes.
in education would be a goal above 12.
Absolutely.
I mean, I think we have to take a technical approach and not just one technology.
Absolutely.
Okay. Tessa, thank you. I'm just picking up some questions from the internet, from our virtual one. The first one is, I'll pull them together and you can answer them. The regulators ready? Because what they mean is, and then they're also suggesting, should there be two regulating bodies, in that one regulating small molecules and another regulating innovative medicines? Second, I think Ivana Knežević, who was the WHO's main guideline writer for biologics, she should have been here. I think her ears are burning, but she wasn't well. And she produced a gene and cell therapy toolkit 4 years ago, and it was launched at the WHO. It's something from her. In that terms, this person is actually asking, should we not put a dam up and prevent the nomenclature of these terms and terminologies and technologies escaping out? And then very cheeky, I don't know who it is, very cheekily he says, and then let AI decide for us. Thank you.
Well, I guess I can speak to the are the regulators ready for this, acknowledging that I'm not and never have worked for any regulatory agency. I think they've demonstrated their readiness by their actions. Certainly in Europe, in the United States, in Japan, to actually be including more patients in various ways to help form their decision-making, and to be to hold up a mirror for themselves and look back and say they want to continue to move forward. And I won't comment on how they structure themselves, but I do know that there's also a lot of effort ongoing in clusters and in other ways for these regulatory agencies to exchange their practices with each other so that we can continue to move this forward. I think it's a very easy thing for people who want to argue against patient involvement to say that the regulators aren't ready, or that there are legal barriers. We should stop hiding behind any excuses and really look at what's happening and what could be happening.
Thank you. That's all the questions. Thank you.
Okay, so I think we are at the end of our time. I would like to thank everyone. It was a fantastic discussion. I think we can conclude for, also with our audience here and online, that the humanizing of the healthcare will be really very important for the future, that the digital health will change our ways of improving healthcare outcomes. And the patient engagement will be one of the key success factors in all of that. So it's important, as you all said, to engage with different stakeholders, considering also not only those who are the traditional ones, and engaging with patients in very early stages and across the entire pathway. Thank you very much, everyone.
Thank you.